Hello, and welcome to the Infectious Disease Podcast. I'm your host, Daniel Reynolds. In this episode, we will hear a discussion of how to implement earlier hepatitis B and hepatitis delta screening recommendations into clinical practice by Dr. Doug Dieterich from the Icahn School of Medicine at Mount Sinai, Dr. Camilla Graham from Harvard Medical School, and Dr. Robert Wong from Stanford University School of Medicine. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now let's get started and hear Dr. Graham tell us about new CDC recommendations for universal hepatitis B screening in the United States.
What would be gained if we were to implement one-time universal hepatitis B screening for all adults in the United States? Well, the first thing is reducing stigma. As we've learned from HIV testing, from hepatitis C testing, when you just have everybody being tested, it destigmatizes it. And often people, when they're told this is something that's being recommended, they're very accepting of it. Right now, our risk-based testing requires you to go through 20 or so risk factors, many of which are not well characterized in the electronic medical record system. It's manual, it's complicated, it doesn't work. It has failed as a strategy. It's heartbreaking to have someone come into your center diagnosed with their hepatitis B at the same time as their hepatocellular carcinoma, and that happens way too often. If you've got a screening program, as opposed to just a vaccination program, you're not inadvertently vaccinating people who actually already have chronic infection and who might be falsely reassured that they've been protected from something that in fact is a serious infection. And this intervention also is cost effective. So the CDC has recently come up with updated screening recommendations, updating those 2008 risk-based screening criteria, which I think we've already described have really failed. And what we are supposed to be implementing, and we're going to be talking today about some practical issues around implementing this, is a triple panel of a surface antigen, surface antibody, and core antibody. In addition, the screening recommendations recommend that all pregnant persons be screened in first trimester with every pregnancy. And then there's a continued periodic risk-based screening recommended for individuals at ongoing high risk for acquisition. There's actually about 15 different categories there. However, if you vaccinate them and they're protected, then you no longer have to screen them. A shout out for the benefits of vaccination.
Great. So now we know what to do, right? Screen everyone and vaccinate pretty much everyone. But I know what you're all thinking. Easier said than done. It's not easy to operationalize this in a grander scale at the health system or even at the public health level. Some of the multiple complex barriers that affect viral hepatitis screening linkage to care. Highlighting just a few domains, there are certainly provider level barriers in terms of having adequate resources, knowledge. Prioritization, I know in primary care, there's often that 100 things to do with all sorts of screening and quality of care. And implementing another aspect is difficult with limited time. Patient level barriers, not all patients, especially hepatitis B patients, many of whom are underserved and minority populations, don't have regular access to care. So how can they get screening if they're not getting, routine preventative care in the first place? And a lot of other competing priorities, both not just healthcare, but also socioeconomic types of priorities. And then health system barriers. How do we implement screening and vaccination at a health system level? We need to have adequate infrastructure, resources, and really the pathway or algorithm to adopt and implement this in an effective manner. There's multiple barriers. And I'm going to turn it over to Doug to talk about some potential methods or strategies we have to address these barriers.
Robert, you're right. You're absolutely right. This is a real problem. And we've actually tried educating providers at the same time as putting in our EMR prompts. And we did a study where we looked at EMR prompt, just education, and then both. And clearly both won out. We put the EMR prompt in for surface antigen for hepatitis B screening, surface antigen core and surface antibody. And we also did like a lunch and learn program for the primary care docs who were actually at the sharp end of the stick. So written communications sometimes help, although they end up in the deleted email. And then, of course, institutional website updates. Clinical decision support tools are very important. We did actually have a bunch of dot phrases so that the primary care docs could just write dot surface antibody. It means you don't have hepatitis B and you're protected. Dot core means you've been exposed and you might be reactivated if you were to get immunosuppressed. So make it easy for them. And then, of course, automatic referrals to the liver clinic for those patients who are S antigen positive. And we've instituted reflex lab testing in the first quarter. We hope it was supposed to start this quarter, but at least from surface antigen, the Delta antibody, and then we're hoping to get the third reflex to Delta PCR, although we can only get a qualitative PCR, not a quant. So tips for leveraging electronic medical records, EMR alerts definitely improve. We actually had it installed in the health maintenance part of the primary care doctors, not one of those yellow pop-ups that they can dismiss. Bundle testing is part of routine care. So it's in there along with colonoscopy, pap smears, and mammograms. Focus on population level guidelines. So that made it much easier for us to get it installed. USPSTF, ACIP, and the CDC to ensure reimbursement and also compliance among the docs. We tried to make it minimal clicks, with just one click in order all retests, and they're relatively self-explanatory. Pre-check a triple panel when indicated, that is, so surface antigen, surface antibody, and core antibody, just one click, make it easy. And then I mentioned already, we wrote these smart sets for patient portal responses, letters and notes, and then smart phrases to help with communications via MyChart. So EMR screening prompt. So quasi-experimental pre-post intervention study. So we started this in October of 22. Education conducted at 3 pilot primary care clinics. Hepatitis B screening rate increased from 4% in September to 23% in March of 2023 in the clinics that received education. So anybody 18 or older, exclude patients if they're known positive or if the serology is already known. All 3 labs negative, vaccinate. S antigen positive, refer to liver. Core positive, and just counsel them about their risks of reactivation should they ever get compromised. We're going to actually open up the panel discussion now and talk about provider level barriers. Laboratory directors, champions. It's easy to find champions for hepatitis C, CAMI, but hepatitis B is a little bit off the beaten path for a lot of folks. Committee approvals for EMR implementation, tips for building criteria, smart sets, addressing patients who were over 59, templated patient letters, educating PCPs, and tip sheets. Robert, Cami, anything you want to say about these things?
Yeah, thanks, Doug. I think all of these are very important provider level barriers, and oftentimes it can be over a little bit too burdensome to think about addressing all of these. But the recommendation I would have is for individuals in different health systems to pick a few key, tangible, doable projects to focus on. Education, as Doug mentioned, is one thing that is very tangible. That's something we've done ourselves at different health systems. Targeted education, either through seminars like this or grand rounds or clinic meetings on very quick tidbits. And we also provided little cards that people can take into clinic or little posters in their clinic to remind them. And it serves as education and a reminder for providers, but also as a stimulus for patients, because patients also see some of these educational posters on the wall and ask, hey, is this something that I should be screened about? Or is this something that I should know about? So it's a good way to engage both patients and providers in even talking about and being aware of hepatitis B.
And I'll just add the point that Dr. Dieterich made about using smart sets and other kinds of support is actually really critical, especially if your health system is going to implement universal vaccination and universal screening at the same time, it gets a little bit complicated. And when people feel frustrated or confused, then they're unhappy and they don't want to implement the program. What we're imagining is you all are either currently champions or you're going to be champions. And so giving you the tools to be able to be successful and reassure people that they're going to be given the support so that they know how to address the results that come in. And because you've given them a series of well-vetted, clear responses that don't stimulate lots of additional patient queries because that's too burdensome.
Cut down on those my chart messages. Okay, Robert, what about other areas?
Yeah, and I think trying to improve screening, I think, is the first step. And we have these universal guidelines, but again, we acknowledge that it's challenging to implement that. But what are the high risk situations or high risk environments where we can really do a service to patients? Of course, I think targeting primary care settings are important. This is usually the first line of defense, so to speak. Patients are engaged with primary care much more so than specialty settings. But beyond that, prisons, there are several studies looking at hepatitis C screening and implementing hepatitis B screening, especially now that's universally recommended, is another great opportunity to identify, diagnose, and then link these individuals to care while in prison or even after they're released from prison. And then these non-traditional settings, very high risk, but also high yield cohorts where we can really identify and link them to care. And these will include opiate substitution clinics, syringe programs, shelters, rehab facilities, behavioral health clinics, sexual health clinics. These are all very outside of the box scenarios where we've done similar things in hepatitis C with success. And I think now is the time for us to think, how can we replicate those successes in hepatitis B? I'm going to turn it back to Doug to talk about another New York program and how they addressed patient level barriers.
Thanks, Robert. This is a comprehensive pilot program in New York City, ran for 4 years, called Be Free NYC. We actually have a World Health Organization recommendation for screening, for universal screening for hepatitis B in countries that have a prevalence of over 2%. In New York City, our prevalence is 3%. And that's, of course, what we know about. It's probably higher, mostly because of the number of immigrants that we have. So we did community education via radio and newspaper advertising, focused on discrete communities, free screening and vaccinations, free or low-cost treatment primarily for patients from Asia, Africa, and the Caribbean. And it was the largest screening program in the U.S., reached nearly 9,000 people. New York City Department of Health has really been a leader in infectious diseases. New HPV cases were increased by 34%. 57% of these patients with positive tests were evaluated by the program clinical services. 72% retention rate after 1 year at the community health center. Charles B. Wang is our FQHC that treats patients for free. And the cost of care was only about $1,600 per year per infected patient. So that's a highly sustainable number when you consider the costs that we talked about before in terms of cost effectiveness. So how do we address these common patient and system barriers? Lack of awareness, educational interventions. It's important to engage community leaders. So we engaged the Buddhist temple, the pastor at the Korean church, and the folks at our local African Community Services Center. Teach back strategies, teach the teachers, language targeted advertisements. Most of our Africans are West Africans, so we have French language there. We have Mandarin, and we have Korean languages, as well as Russian, because there's about 1 million Russians in the U.S., large numbers of Delta in the former Soviet Union folks. Get PCPs involved and get community-based, non-traditional testing sites, so it doesn't have to be STI clinics. Address the stigma and the fears of treatment. So acknowledge this disconnect between providers and patients. Segregate service delivery, engage stakeholders, and then align with CDC universal screening recommendation. And that's made it a lot easier to get us through all the committees that were necessary to get this instituted in our institution. Robert, key take-home
Yes.
point.
Hopefully, we emphasize for you all that rates of hepatitis B testing and linkage to care are still low, and there's a lot of work we need to do to improve screening, testing, diagnosis, linkage to care, with the goal of linking them and reducing long-term risk of disease progression and mortality. Key highlights: there are new recommendations now for universal testing of all adults for hepatitis B, triple panel, and then near universal vaccination for those that are appropriate. But we know from the data that we show, major gaps remain, and it's complex. There's no one size fits all, one answer that addresses all of these. And we acknowledge that a really comprehensive approach is needed, individualized to each health system, community, demographic, to really address in a patient-centered way the multifaceted and complex barriers to timely diagnosis and subsequent linkage to care and treatment for patients with chronic hepatitis B. So hepatitis delta, the challenge with delta is that there's under-awareness, under-testing, and therefore contributes to underestimation of true prevalence. So who to screen? This is probably where some of the confusion lies and contributes to under-testing. EASL updated their guidelines this year and really recommends everyone with hepatitis B to be tested for delta, the antibody followed by RNA testing. AASLD is in the process of updating their guidelines, but their 2018 guidelines still recommends a risk-based approach, which we've seen is unfortunately a setup for failure in HIV and hepatitis C, and hopefully we will move towards more universal-based testing. APASL, the Asian Society, recommends, similar to EASL, pretty much testing everyone, and WHO is a little bit older, but has no recommendations at that time for delta. How does improving testing improve diagnosis? So this is one of many studies that show the impact of reflex testing. This is a study in Spain, in Barcelona, which showed really, as you can see here in the figure, before and after their intervention, which was reflex testing of all patients with surface antigen positive. There's a dramatic increase in a number of individuals tested. And then most importantly, there's a 5-fold increase in individuals diagnosed. So these are people that had delta that were not aware of it. And by implementing reflex testing, we were able to identify them and plug them into appropriate care and treatment. So what is the cascade? And this is emphasizing the complex testing cascade for delta and where patients can fall out of care. First, you have to see a provider. You get tested for surface antigen, diagnosed. Then you need to get anti-delta antibody testing. If that's positive, then you have to get RNA testing, and then you have to get plugged. So you can see it's a multi-step complex cascade. And along each step, there are opportunities for loss of follow-up. And if we can implement reflex testing to test all of these patients for delta, and then even reflex to RNA positive or RNA testing for those that are positive, I think that can eliminate a lot of these potential gaps and really improve testing, diagnosis, and linkage to care. So how do we accomplish that? What are some barriers? And I'm going to turn that over to Cami.
I think part of our challenge has been 10, 15 years ago, the testing for Delta antibody especially wasn't as sensitive and specific as maybe we're used to seeing with other diagnostic tests, but they have improved over time. There's actually a meta-analysis looking at the performance of hepatitis D, IgM, and Ig testing, and they perform very well. So I don't want anyone to take away the idea that we've got a performance problem. The commercial labs have good quality antibody testing if you were to implement reflex testing. And then the problem with the RNA is not so much each individual assay, but there's some variability across the manufacturers. And so we've seen this before in early days of HIV. If you shifted from one manufacturer to another, you need to reset people's baseline. We know how to deal with this, but just demonstrating that somebody is RNA positive is what distinguishes that they have active infection. So I think our challenges on the lab side are really very minimal at this point. And it's really educational challenges. If you've got conflicting guidelines, that always adds challenges. Having to do risk-based testing, we've already said it's failed in almost every other infectious disease. It's probably not going to work here. And then the last thing is, if you don't know what you're going to do with the information, as a clinician, you're often a little bit reluctant to take that on. But I think what we've tried to describe today is you will monitor these people more closely if you know they are co-infected with Delta. And there are treatments on the horizon. There's a drug approved in Europe that's still an investigational drug here in the United States. There's some really exciting work done on functional cure in hepatitis B. So I think we have a lot of hope on the horizon for therapies that could really change the course of disease for these individuals as well.
Okay, barriers preventing with patients who are co-infected, stigma, financial difficulties, of course, language barriers for sure, and lack of familiarity with the healthcare system, as many patients get referred also because they're from countries where the healthcare systems are easier to navigate than ours. So how do we keep these people in care? We'll encourage patients to establish with a provider and keep follow-ups. Well, that's why we engage our navigators and coordinators. We get them involved with our Hep C patients, and we now have them working with our hepatitis B patients as well. Get them to show up, help them with transportation needs if they need it. And then, of course, knowledge can change health behaviors, culturally and linguistically appropriate outreach, increased education of providers, especially primary care providers. We mentioned that we were doing that, lunch and learns. And it does work when we combine it with the EMR prompt. And then, of course, Cami mentioned we do have some treatment options, some of which are available actually on compassionate use now, which are very effective and promising for the future. And, of course, translations into native languages about information for the patients. Panel, why do you think risk-based screening will fail?
Yeah, I can definitely start with this. I think we've seen similar evolution with risk-based into universal with HIV, Hep C, and excited to see that with hepatitis B. I think for Delta in particular, and we didn't have enough time to touch on this, but we also saw in many studies that some patients with Delta don't have these traditional risk factors that we think of. They may not be specifically from countries where there's a high risk. And all of this is met in the idea that we don't really know where the pockets are, where are the populations, what are the risk factors, what is the prevalence. So using a risk-based approach when we don't even know how to target those specific populations, I think is a setup for failure. And I think that many programs, we've tried to pilot this. I think several other programs, including also Doug in New York and others, have tried to look at the potential benefit of a reflex testing. And I'm hopeful and waiting to see some of the data, especially cost effectiveness data from reflex testing all B patients for Delta.
And I'll just add, we mentioned this with the hepatitis B, but it's really important to involve your laboratory directors because there's issues around sample collection, storage, the appropriate sample that they need to have input into. And then there's some issues around billing that they need to think about. And whenever we want to do reflex testing, we try to bring in those laboratory directors early to help us think through just the logistics of that.
Yeah, that's an important point, Cami, and we have done that actually, and it's worked reasonably well. Key take-home points, hepatitis Delta. Establishing the Delta diagnosis is important, obviously, to guide treatment. Guidelines vary on whom to test, so we're still trying to test everyone who is S antigen positive because you never know. I don't think the risks for Delta are really well established. As Robert mentioned, EASL, I think we agree with EASL more than ASLD. Risk-based screening results in underdiagnosis, and most experts do agree that universal screening in patients who are S antigen positive should be done. Reflex testing can significantly increase screening and reduce Delta burden. So let's talk about some questions. First one is from Kathy. There's evidence that suggests the intervention of educating physicians has very little benefit. And further, it has poor lasting value. Do you think this is different in your institutions or with this disease state?
I will say, when we were implementing a hepatitis C screening a long time ago, we really tried to limit the education component and really try to create a comprehensive medical decision support infrastructure within EMR, because we're a large system just spread out, much like I think you are as well. And we increased screening by 400% in a couple of months. So a well-designed EMR prompt system with, again, those smart sets, standard response letters, pre-filled order sets, creating that screening order set so people don't have to remember which 3 tests to select. Those all make a big difference.
One of the things we did in the residence clinic too, it's not just the education alone. It has to be the education plus all the EMR efforts. Yeah. But getting the residents to do it, it didn't work well for either until we posted the score sheet up every week about how they were doing with universal Hep B screening. And all of a sudden it went from like 4% to 90%. Because every week they came in and said, where am I? Number 1, number 2, number 10. They wanted to go up that list. So a little competition sometimes helps actually as well. I want to get this one from Mohammed to Robert here. Robert, I think we're overlooking the difficulties, barriers physicians are facing. How many hospitals, clinics in the U.S. have funding to test Delta without any risk factors given by patients?
We talk conceptually that Delta is important and we really should test everyone. But you bring up a good point. The practical aspect of how to operationalize that and get that done has multiple challenges. I think first and foremost is the guidelines. EASL guideline and the APOSL guideline do recommend everyone with hepatitis B being tested for Delta. And I'm hoping that with time, AASLD will be updating their hepatitis B guidelines, I think this next year. So I'm hoping that there may be some movement in that respect with testing for Delta more universally in hepatitis B. I think it has to start with the guidelines and then payers and coverage will then follow. But I agree with you that now it's challenging in terms of costs and finances to really justify testing depending on the health system and the patient's insurance.
Yeah, I think most of the time insurance pays for it. And we've heard in the past, risk-based screening has not really panned out to be very successful. My sickest Delta patients don't meet any of the standard risks.
I'd like to thank Dr. Dieterich, Dr. Graham, and Dr. Wong for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on Are We Early Enough? Key questions in timely management of HBV and HDV on our website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.